Hi there, my name's Will Niven. I'm a consultant in emergency medicine at the Royal Surrey Hospital, and I'd like to chat to you about how to pick a topic for your QIP. Here are the main objectives. We'll go through some important questions you need to ask yourself, how to find material in your workplace, understanding a bit of the context of that topic within your environment, and then how to refine your idea into something workable. You've got to be a bit like Baldrick and come up with a cunning plan. And one of the ways you can do that is by considering these idea sources. So observation is a good one. Chatting with people within your department, other nurses, other doctors that are either working there now or have worked there before. Complaints and incidences may actually reveal a particular theme or an area that needs improvement, and that can often come up at governance meetings. There's a wealth of literature out there now, previous QIPs that have been done for the FR Chem and then BMJ Quality that provide ideas for quality improvement. And then conferences are often a good source of ideas as well. The first question to ask is really where you're working, and we've got some art history for that. This is Hieronymus Bosch's Garden of Earthly Delights, which is an incredible piece of art and must have been painted on shrooms. But there are three things to take from the three panels that apply to emergency departments. Firstly, at the top, you notice the common horizon delineated by the yellow line. What do I take from this? Well, whether you're working in a rubbish department or an amazing one, the same issues will come up. The 4-hour target, delayed pain relief, flow, slow coronavirus testing, August changeover, and dealing with difficult specialities. Similar problems often mean that the emergency medicine hive brain has been considering them too, so take heart. The second thing to note is that there are lots and lots of people in the garden, all with their own agendas and carrying them out in a confusing and apparently unrelated manner. However, the longer you're there, the more it begins to make sense. As it is with any emergency department, the longer it is, the more you kind of have an understanding of their institutional memory. So my advice is to take an interest in the people in your department and pay attention in the break room. And the third point is that there aren't many people in the Garden of Eden. In fact, there's only Adam and Eve and I think God. Whereas in hell, there are a whole lot of people struggling. And the moral of that is, the moral being that your ideas should bring water and paracetamol and not habaneros and petrol. Building on that idea of where you're actually working, you need to think about what your bag is. What are you really into? What kind of stuff do you know lots about, and do you actually care? You need to understand how a project's going to track to your strengths and interests. After all, you're going to be doing it for a year, and you're far more likely to get it done if you believe in the change you're bringing. The great news is that the QIP is far less restrictive in terms of material than it was previously. So pre-hospital medicine, ultrasound, educational initiatives, and the Green ED are all potential topics. The next question I ask is what's actually going wrong? So are your processes inefficient? Is there a delay to X-ray? Is there increased time to analgesia? What's patient flow like? Is practice out of date? It's always getting updated. There's always new evidence coming on tap. Is your practice non-compliant? How do you perform according to the RChem audit standards? Is there a patient safety issue? And what are reasons for things being the way they are? Have you seen it done better? What examples of excellence or innovation have you seen in other departments? Do you think any of those instances of good practice could be applied in yours? And a word of warning over there, just be careful about how you introduce the idea that another department is doing something better. The next question is, what do others say? So what does your department lead think might be the main issues? Have a chat to the governance and the QI leads, because they're often going to have some pretty good insights into where things are going wrong. Keep your nursing team on board and the healthcare assistants as well, because they're very often the glue that sustains your project after you've left. And it's often helpful talking to the network of trainees or non-trainees in the blogosphere and finding out, what's happening on the grapevine in the department that you're working in. What areas do they think possibly require address or change? Question 5: what's the broader context? And by that I mean what's happening in the patient journey downstream after they've been in the ED. The next stop is often an acute medical unit, might be ambulatory care, or it might be another department. And often those departments have got their priorities. They may be looking at a similar part or a different part of the problem somewhere else in the patient journey. And what you want to avoid is duplicating their work. And if possible, really, it can be fantastic because you may deal with a different part of the problem, and you can work together to ensure that patient care is joined up and of a high quality. And it's also worth sometimes having a chat with the trust and quality improvement team and patient safety committees, because not only will they give you evidence or might know of information sources that you can use to justify your project, but also they'll support you through your work. And then the next thing to consider is what's going on upstream. So by that I mean what's happening in the primary care network with GPs, the ambulance service and community health teams. Every project that we do in the emergency department is going to have a footprint, potentially in the rest of the hospital or after the patient's left the hospital and gone back into the community. National issues help highlight common themes that come up within emergency medicine: missed hip fractures, missed sepsis. And what that can often do is, particularly if there's been a safety alert, it just gives you more of a reason or more of a justification for why this project is important. So in summary, what's your bag? What's going on in your ED? What's happening in the hospital at large? And what are the national issues? Here's an example. You could be a patient safety hawk and you've noticed that there might be a problem with reattenders. You discuss it with your clinical lead, and this confirms that the reattendance rate is 8%. The CQC are due in the next 6 months. And on their last visit, they mentioned that whilst the department got a good overall rating, this problem was highlighted as an area that required addressing. A quick look at the National RChem Consultant sign-off audit for high-risk attendances showed that your department fell well short of the expected standard. You're never going to have any difficulty justifying why this project needs to get done, and the degree of urgency will mean that you will get the support that you need. The second part is about refining your idea, and I think the most important question is, are you going to be able to measure this? If there is anything that should seriously affect your decision, it's the ease with which you'll be able to generate a range of measures. Think about what's already measured in your department at this point. Waiting times, time to x-ray, time to analgesia, previous RChem audits or Datix. Keep a huge amount of data that you could use. Think about what other departments might already be measuring in terms of performance, and at my trust, for example, the oncology service are already measuring door-to-needle times for neutropenic sepsis. Remember, no measurement, no project. Try and have a patient focus, but it's not essential, and keep it really simple. And just to remind you, in terms of the model of improvement, this is where measurement really focuses on the second part over here. How will we know that a change is actually an improvement? Question 7, who's in my team? Are you going to be able to show that you led the team? Will your team actually care about your project, and who's going to do it when you're gone? And this is once again reiterating an earlier point. If you don't involve members of the permanent staff, including nurses and doctors, then it's very unlikely that the project will continue to run after you've left. And then question 8 is really a question around remit. How much are you trying to achieve? You can't hope to solve the UK's exit block problem. That's just too big, and it's too complicated. Equally, if you focus on hereditary angioedema, you're never going to be able to generate a set of metrics or get together a team that can solve that very, very rare problem. One of the best ways to think about this is a bit like fractals. So every issue has a number of different sub-issues that make up the whole. And emergency departments are complex systems with lots of variables contributing to how well they function. And examples of these variables are things like staff, environment, availability of equipment, and processes. If these variables could then be considered as separate colors, you need to decide how large a triangle you want to focus your project on. Too ambitious, you never get it done. So small you can fix it on your own, it's not really a quip. Here's an example: trust neck of femur care. Orthopedic operative care is slightly outside of your gift to fix. A&E NOF management is something that you could potentially affect, but this is also in and of itself quite a big topic. So within that, you're going to have time to x-ray, whether or not your staff are measuring, or your clinicians are measuring AMTS, whether or not the patient's been put onto a pressure relieving mattress, and finally the whole issue of pain relief. Has it been given in a timely fashion, and has its effect been monitored? If we were looking at reattenders, ward discharges that return, not something that you're going to be able to fix, but you could do something about A&E reattenders. And amongst those, you're going to have your frequent flyers or your very high intensity users, misdiagnoses, patients that come back for dressings, and then finally, at the previous trust I was working at, sickle cell patients formed a significant percentage of our reattendance figure. So if we were going to perhaps target the pain relief side of fractured neck of femur care, you might realize that the quality of fascial blocks is not really being monitored, and no one is checking if they actually work. And this is obviously important to patient experience, would require the cooperation of nursing staff in your department and up on the wards to monitor pain scores, and will probably require some teaching from anesthetics as well. Check, check, check. It's also something that's easy to measure, and you'll be able to complete it in the allocated time frame. With the reattender problem, you realize that the topic of misdiagnoses is actually a relatively small proportion of reattenders and too heterogeneous to address in the time frame you have. However, a hematology consultant has recently left the department in the past year, and pain protocols are not being updated. There's been a real confusion about the type, route, and duration of analgesia, and this has probably resulted in increased complaints and repeat attendances. And if you were going to take on this topic, it would naturally involve engaging with the sickle cell nurse specialist, the new hematologist, nurses, and junior doctors, and it's clearly something that patients care about and would appreciate being addressed. So, in summary, and forgive the obscenity, what shit do I like? What shit's going wrong? Why is my department shit? Who else knows about this shit? How much of it can I actually sort out? Who can help me clean this shit up? And can I measure it? And if in doubt, ask an expert. Thanks very much.